Welcome back to the deep dive. Today, we are strapping in for what is maybe one of the most clinically intensive, but also, profoundly rewarding subjects in med-surg nursing.
It really is.
We're talking about the management of patients fighting hematologic
Right.
neoplasms.
We're essentially going deep into the world of blood cancers. It's a landscape where, everything collides: immunology, cellular biology, pharmacology, and really acute care.
And this is exactly the knowledge you need if you're a learner. Maybe you're preparing for an oncology rotation, or you're just trying to get that next level of understanding in these really complex diseases.
For sure. And we've taken the highly structured, evidence-based roadmap of Chapter 30 from Brenner and Sudduth's Medical Surgical Nursing. Our mission today is to deliver a really comprehensive, structured shortcut.
A shortcut, I like that.
Yeah, and we're focusing not just on the definitions, but on the clinical why. Why do these cells go rogue? How does the treatment actually work? And most critically, where do the life-saving nursing interventions lie?
That structure is so vital because we have a huge amount of material to get through. We have to start at the cellular level, compare and contrast the different leukemias.
Acute and chronic, myeloid and lymphoid.
Right. Then we'll move into the myeloproliferative disorders, tackle the whole varied world of lymphomas, and then dive into the unique threat of multiple myeloma.
And we'll anchor it all using that systematic framework of the nursing process.
Okay, so to set the stage, let's nail down some of those core concepts.
Yeah,
The starting point for all of these diseases is hematopoiesis.
exactly. You can think of it as this beautifully complex factory floor right in the bone marrow where all our blood cells are formed and mature. It all starts with one cell, the hematopoietic stem cell, which then differentiates down one of two main pathways.
And that fork in the road is just crucial to understand. On one side, you have the myeloid pathway.
Right.
And these are the fast, frequent production lines for, your red blood cells, your platelets, and most of your white blood cell soldiers, like neutrophils and monocytes.
And then on the other side is the lymphoid pathway. That's what gives us our specialized immune system, the T and B lymphocytes. Normally, this whole system is just exquisitely controlled by growth factors and feedback loops.
And when malignancy strikes, it's because those regulatory mechanisms have just failed. We get this uncontrolled proliferation. So what's the common thread pathologically that links all these varied diagnoses together?
It's the concept of a clonal stem cell disorder, or you might hear it called clonal hematopoiesis.
Okay.
What this means is that the entire malignancy, whether it's leukemia or certain lymphomas, it originates from a single abnormal stem cell, a single cell that just starts replicating itself endlessly, producing this dysfunctional army of cells.
And then, depending on where that abnormality takes hold, we get our three main categories. First up is leukemia.
Leukemia, yeah. The neoplastic proliferation of these dysfunctional cells, so granulocytes or lymphocytes, right into the bone marrow and circulating blood. And they usually prevent the production of any healthy cells,
Second is lymphoma.
which are neoplasms that arise from the lymphoid tissue itself. So they typically start in the lymph nodes, and they often involve the B lymphocytes.
And then finally, the third category is multiple myeloma.
Right, which is a cancer not of the general lymphocyte, but of the most mature B cell, the highly specialized antibody-producing plasma cell.
So these are our three battlegrounds. Let's start with the four forms of leukemia. We need to compare their speed, their origin, and of course, their prognosis.
Sounds good.
So all the leukemias share that same mechanism of unregulated leukocyte proliferation in the bone marrow. But when we talk about acute versus chronic, we're really talking about speed and maturity, aren't we?
Exactly. This is a foundational clinical concept you have to grasp. Acute leukemia is an emergency. Full stop. It has an abrupt, rapid onset symptoms, usually develop within just a few weeks.
So really fast.
Incredibly fast. And the core pathology is that the cell development has been halted at its most immature stage, what we call the blast phase. The bone marrow just gets packed with these undifferentiated blasts that can't function, and that leads to immediate severe cytopenias.
So the high volume of cells doesn't actually translate to any functional immunity.
Not at all.
And conversely, chronic leukemia is more of a slow burn disease, right? It evolves over months or even years.
Correct. In the chronic forms, the cells are mostly mature, or at least they're capable of some limited function. And this is why the disease trajectory is so much slower. It often allows for these watch-and-wait periods before you need any aggressive intervention.
Okay, so let's start with the most common acute form in adults. Acute myeloid leukemia, or AML.
Right, so AML is defined by this clonal blast cell development that arises from genetic mutations in the myeloid hematopoietic stem cells. These mutations basically grant the cells a growth advantage and a resistance to apoptosis.
Apoptosis being programmed cell death.
Exactly. So the result is a bone marrow that is increasingly just choked by these leukemic cells.
Yeah.
And that crowding, that's the fundamental reason you see pancytopenia.
Right, not enough healthy red cells, so you get anemia, not enough functional white cells, so neutropenia and infection, and not enough platelets, which means thrombocytopenia and bleeding. Just not enough of anything.
It's critical to understand the epidemiology here. AML is the most common form of leukemia, and tragically, it's the most common cause of death from all leukemias in adults. The median age is 68.
And the risk factors are pretty comprehensive, so you need to consider them when you're taking a history.
Absolutely. Increasing age, male gender, and then environmental exposures, things like benzene, pesticides, and significantly prior exposure to chemotherapy agents like alkylating agents used to treat other cancers.
So when a patient presents, the physical manifestations directly reflect those cytopenias we just talked about. We're looking for fever, often with no clear source, because of profound neutropenia.
And profound fatigue, pallor, dyspnea from the anemia.
And signs of hemorrhage like nosebleeds, epistaxis, petechia, and those deep ecchymosis from the low platelets.
And you also need to be vigilant for symptoms of organ infiltration. Things like bone pain from marrow expansion, an enlarged liver or spleen, and a classic, though not always present, sign in AML gum hyperplasia.
Right, that's figure 32 in the book. It's where the gums become visibly enlarged and inflamed because of that leukemic infiltration.
It's a very striking visual, and for diagnosis, the source emphasizes the hallmark is a bone marrow analysis showing more than 20% blast cells.
But you mentioned a critical subtype, acute promyelocytic leukemia, or APL. What makes this subtype so clinically terrifying, but also potentially curable?
APL is a true oncologic emergency because it is highly associated with disseminated intravascular coagulation, or DIC.
DIC, okay.
The malignant promyelocytes, they release factors that trigger the clotting cascade, and that leads to these fatal coagulopathies. However, the good news is that APL is uniquely sensitive to therapies like all-trans-retinoic acid, or ATRA.
And what does that do?
It prompts the malignant cells to mature. So it offers a high potential for cure if the patient can survive that initial hemorrhagic crisis.
Which leads us directly to medical management, which sounds incredibly aggressive. A total reset of the patient's physiology. The goal is complete remission.
It is. The first phase is induction, which is designed to rapidly destroy all leukemic cells. We use high-dose chemotherapy, primarily cytarabine, combined with an anthracycline like daunorubicin.
And this is a brutal phase.
Oh, it's brutal. Because it indiscriminately targets all rapidly dividing cells, the resulting severe myelosuppression means the patient is hospitalized for, 4 to 6 weeks.
4 to 6 weeks in reverse isolation. The absolute neutrophil count, the ANC, plummets to near zero, and platelets drop severely. So this intense supportive care period requires just constant vigilance, managing transfusions.
ARBCs and platelets.
Yeah, and treating any fever immediately as a life-threatening infection.
And here's a critical clinical nugget, especially regarding complications. We mentioned granulocytic growth factors, GCSF, can shorten neutropenia. But they have to be used judiciously.
Why is that?
They are contraindicated in APL except for refractory infections because they dramatically increase the risk of something called differentiation syndrome.
Wait. Okay, that sounds counterintuitive. If the APL therapy, ATRA, is trying to make the cells differentiate, why is differentiation syndrome a bad thing?
That is a great question, and it's an advanced insight. Differentiation syndrome isn't caused by the drug failing, it's caused by the drug succeeding too fast.
Oh, wow.
As that massive population of malignant blasts rapidly differentiates into mature cells, they release this huge load of inflammatory cytokines. This causes systemic capillary leak syndrome, manifesting as fever, weight gain, acute respiratory distress. It's a huge problem.
So what's the treatment?
High-dose corticosteroids, not just stopping the chemo. Understanding that mechanism is absolutely vital for any nurse in this setting.
So once the patient recovers from that initial assault and hopefully achieves remission, they move to consolidation.
Right. Multiple cycles of therapy aimed at eliminating any undetectable residual cells. And for long-term cure, especially in younger or higher-risk patients, an allogeneic stem cell transplant, or HSCT, is common.
Let's revisit the major dangers again. Bleeding and infection are the leading causes of death. But we have to detail the assessment and prevention of tumor lysis syndrome, or TLS, which you flagged as a critical oncologic emergency.
Absolutely. TLS happens when the sheer volume of tumor cells lies by the chemo releases massive amounts of their intracellular contents. We track 4 key electrolytes, rapidly increasing uric acid, potassium, and phosphate, and then a subsequent drop in calcium.
And the clinical consequences of those rapid shifts are systemic, right? This isn't just a lab value problem.
No, it's a huge clinical problem. High uric acid and phosphate risk acute kidney injury from crystallization. But the hyperkalemia, that's the most immediate life threat because it wrecks fatal cardiac arrhythmias.
So prevention is key.
It's everything. It involves aggressive IV hydration, often 3 liters a day to flush the kidneys, combined with uric acid management. We use allopurinol for prophylaxis or resburicase, which metabolizes uric acid much faster for high-risk patients.
Okay, let's shift gears now to CML, chronic myeloid leukemia. This is also a myeloid disorder, but the presentation is that slow, steady increase of cells ranging from blasts to mature neutrophils.
And the defining feature, the ultimate clinical nugget for CML, is the Philadelphia chromosome.
Okay, what is that exactly?
It isn't just a label. It's a specific translocation between chromosomes 9 and 22. And this creates a chimeric BCR-ABL fusion gene. This gene produces a protein, a tyrosine kinase, that's constantly active. It acts as an unrelenting go signal, telling the cells to proliferate excessively.
And this disease typically progresses through 3 phases. It starts in the chronic phase, which is often found by accident, right? Extreme leukocytosis, but very few symptoms.
Right. Then it moves to the accelerated phase, characterized by worsening cytopenias, new chromosomal abnormalities, and the start of constitutional symptoms like fatigue and splenomegaly,
And then the final, most dangerous phase is the blast crisis.
which transforms the disease into something clinically identical to acute leukemia, usually AML. The leukocytosis can be extreme, sometimes exceeding 100,000 per cubic millimeter.
And that leads directly to leukostasis.
It does. When the leukocyte count is that high, the sheer mechanical volume of cells physically obstructs blood flow in the capillaries, especially in the brain and lungs. This leads to immediate, life-threatening symptoms like acute confusion, visual changes, and severe dyspnea. It requires emergency intervention, sometimes leukapheresis, to physically remove the white cells.
The treatment for CML, though, unlike AML, is often focused on managing the disease, keeping a patient in that chronic phase using tyrosine kinase inhibitors, or TKIs.
TKIs, imatinib, nilotinib, dasatinib, they're the cornerstone. They directly target and block that BCR-ABL protein. They effectively turn off that constant go signal, which forces the malignant clone population to decline.
So for the nurse, the focus shifts dramatically here. You're not managing intense inpatient chemo side effects, but rather the highly nuanced long-term toxicities of these daily oral agents.
Exactly. And we need to detail these specific toxicities. Imatinib is notorious for causing periorbital edema and fluid retention. Dasatinib carries risks for severe myelosuppression and 2 critical cardiopulmonary issues, pleural effusion and a prolonged QT interval.
Okay, so that's a cardiac risk.
A big one. And nilotinib is also associated with significant cardiotoxicity, including vascular events and prolonged QT. So for a patient on dasatinib, the nursing responsibility goes way beyond just monitoring a CBC. They need mandatory serial ECGs and possibly pulmonary function tests to screen for that effusion.
And because all TKIs rely on the P450 pathway for metabolism, patient education on drug-to-drug and drug-food interactions like grapefruit juice is non-negotiable.
Absolutely. Altering that TKI level risks either severe toxicity or therapeutic failure.
And this brings us back to a critical nursing management concept for CML adherence. If the patient stops taking their TKI, that BCR-ABL signal reactivates and the disease comes back fast.
Right. Table 30-1 in the source outlines the common barriers to adherence, which is vital for education. It's not just forgetting, it's a poor understanding of the dose regimen, or unmanaged side effects leading the patient to self-reduce the dose. Nurses have to help develop clear, manageable schedules and aggressively manage those toxicities so the patient doesn't quit.
Let's pivot now to AL, Acute Lymphocytic Leukemia. Here, the proliferation starts in the lymphoid stem cell, producing immature lymphoblasts. This is the most common form in children, but it sees a rise in incidence, again, in older adults.
Pathologically, it mirrors AML. The proliferation of non-functional cells leads to severe cytopenias. However, the crucial clinical distinction with LL is its tendency for extranodal infiltration, specifically into the central nervous system, the CNS.
Why is the CNS so vulnerable here?
The leukemic cells cross the blood-brain barrier pretty readily and infiltrate the meninges, the testes, and the breasts. So symptoms of CNS involvement, cranial nerve palsies, headaches, vomiting, that signals an urgent need for intervention.
And because of that high CNS risk, The treatment protocols are really complex: induction, consolidation, maintenance. But the critical mandatory element is preventive intrathecal chemotherapy.
Right, injecting chemo directly into the spinal fluid and sometimes cranial radiation, even if the initial CNS imaging is negative. You're preventing sanctuary sites where the cells could hide.
The good news is that lymphoid blasts are highly sensitive to corticosteroids, particularly dexamethasone and vinca alkaloids. And this is also where we see the cutting edge of oncology, CRT cell therapy.
That's a huge shift in approach. Instead of traditional chemo, we're modifying the patient's own T cells to identify and obliterate the malignant cells. That level of immune customization has dramatically improved outcomes, especially in relapsed or refractory LL.
But these treatments, effective as they are, bring their own unique toxicities. High-dose corticosteroids increase susceptibility to viral infections. Asparaginase, a common agent, significantly raises the risk of thrombosis.
And nurses have to monitor for vascular necrosis, which can affect the joints, especially in pediatric or young adult patients.
Okay, our final leukemia, CLL, chronic lymphocytic leukemia. This is the most prevalent adult leukemia in Western countries, with a median age of 71.
This is a disease of immortality. It's a malignant clone of B lymphocytes that has lost the ability to undergo apoptosis, so they just accumulate in the marrow, blood, and lymph nodes.
And a key point for veterans is its documented association with Agent Orange exposure.
That's right. And many CLL patients are asymptomatic. They're discovered only when routine labs show this persistent, unexplained lymphocytosis. But as the disease progresses, massive, sometimes painful, lymphadenopathy and splenomegaly can develop.
So the assessment of constitutional symptoms becomes a major prognostic indicator.
It does. You have to actively screen for B symptoms. That's unexplained fever, drenching night sweats, and unintentional weight loss of 10% or more. Their presence signals that the disease is progressing and you need to start or intensify treatment.
And the immune system suffers a double blow here. Not only are the malignant cells dysfunctional, but the disease profoundly impairs T cell function.
Which leads to a high susceptibility to severe and recurrent infections. Viral infections like herpes zoster are common, as are infections from encapsulated bacteria.
For asymptomatic early-stage patients, the consensus is often watch and wait, right?
Yes, we avoid therapy until the patient is symptomatic, has evidence of cytopenia, or rapidly progressing lymphadenopathy. Once treatment is initiated, the regimens usually include highly effective immunotherapy like anti-CD20 monoclonal antibodies, such as rituximab combined with chemo.
And we're seeing targeted therapies dominate, especially TKIs like ibrutinib, which are used when high-risk genetic mutations are identified.
But each agent requires specific monitoring. Fludarabine causes prolonged severe marrow suppression. Alemtuzumab carries such a significant infection risk that patients need mandatory prophylaxis against viruses, fungi, and bacteria. And since TKIs are now standard, nurses have to track cardiovascular risk factors closely.
Finally, nursing management focuses heavily on mitigating that severe immunodeficiency.
It does. This includes administering 5E immunoglobulin, or IVA, for select patients with recurrent severe infections, ensuring all necessary vaccinations are given, but crucially, avoiding all live vaccines. And comprehensive annual skin exams are required because of the increased risk of secondary skin cancers.
We've established the terrifying clinical profile of acute leukemias, AML, and all. Now let's frame the nurse's role in managing these patients during the acute high-risk phases, using the nursing process as our guide.
This segment is where the rubber really meets the road. During the induction phase, your patient is an extreme safety priority, hovering near death due to myelosuppression. Every single intervention has to be systematic and serial.
The first critical assessment hurdle is infection. Why is recognizing infection so difficult in an acute leukemia patient?
Because of the lack of circulating functional neutrophils, the entire inflammatory response is blunted. You just won't see pus or massive swelling or often not even clear radiographic changes initially.
So a dry cough, a slight increase in temperature, or a subtle change in mental status might be the only sign of a severe infection.
Exactly.
Yeah.
That's it. Which means a fever in a neutropenic patient is always an emergency. You cannot wait for classic signs.
You just can't.
Immediate cultures and initiation of broad-spectrum IV antibiotics are mandatory, often within the hour. Triage depends entirely on the lab work. We track the leukocyte count, platelets, coags, but the gold standard for infection risk is the absolute neutrophil count, or ANC.
For our listeners, let's just quickly review the ANC calculation and what it means.
The ANC is calculated by taking the total white blood cell count multiplying it by the percentage of segmented neutrophils plus the percentage of bands, and dividing by 100. An ANC below 1,000 signals significant risk, and an ANC near or below 500, which is common during induction, means the patient is profoundly neutropenic and requires strict protective isolation.
Based on this ongoing threat, the nursing diagnoses are comprehensive. We're managing the immediate life threats, risk for infection and risk for hemorrhage.
But we also address the pervasive acute challenges: impaired oral mucous membrane integrity from mucositis, impaired nutrition, acute pain, severe fatigue, and the significant psychosocial diagnoses like anxiety and dysfunctional grief.
And the list of potential collaborative complications drives our clinical focus. We've already detailed infection, bleeding, DIC, and tumor lysis syndrome. We also worry about cardiac toxicity from anthracyclines, renal dysfunction, and the long-term threat of infertility.
A huge list of things to watch for.
Let's start with that common, distressing side effect of chemomucositis. How do we manage that painful, ulcerated oral mucosa that impacts everything from speaking to eating?
Meticulous oral care is paramount. We use soft bristled toothbrushes or sponges, and frequent rinses with saline or baking soda solutions both before and after meals. For severe pain, we often use topical oral rinses, sometimes containing lidocaine or a magic mouthwash preparation.
Is there a critical safety point in using those oral anesthetics?
Yes, patient teaching has to include the warning against biting their tongue or their cheeks, especially before eating, because the numbing effect eliminates the pain response that prevents injury. For severe systemic pain, PCA may be necessary.
And nutritional management is tied directly to that. These patients need high-calorie, high-protein intake, but they just can't tolerate typical food.
So we encourage small, frequent feedings of soft, moderate temperature foods, avoiding anything acidic, spicy, or extreme temperatures. And nutritional supplements are used liberally. When a pain is just too much or the patient is severely malnourished, we quickly transition to considering TPN, total parenteral nutrition, to ensure they get what they need for marrow recovery.
What about managing generalized pain and discomfort, like fevers and rigor?
Fevers often bring severe shaking chills, the rigors. Acetaminophen helps reduce the fever. But when implementing cooling measures, we use cool sponging, but we have to avoid using ice packs on major areas.
Why is that?
Ice causes peripheral vasoconstriction, which actually traps heat centrally and can make the patient feel worse, delaying heat dissipation. Gentle massage can help with muscle aches. And we can't forget the psychological aspect. Active listening is a continuous nursing intervention.
Absolutely. Next up, managing fatigue and activity intolerance. The fatigue from anemia and chemo is just debilitating, far beyond normal tiredness. The tendency is to keep the patient in bed, but we have to resist that completely.
We do.
Why is resisting deconditioning so important during these long hospital stays?
Because 4 to 6 weeks in bed leads to rapid muscle wasting and deconditioning, which severely compromises their ability to tolerate subsequent therapy and recovery. We have to balance rest with activity. At a minimum, the patient needs to be sitting in a chair while they're awake.
And if they are severely neutropenic, how do we mobilize them safely?
Ambulation is still encouraged, even if it's just in the hallway, using a HEPA filter mask for protection against airborne pathogens. The nursing research profiled in the source material confirms this approach. Studies show that encouraging moderate exercise and optimizing sleep significantly improved outcomes and quality of life by discharge.
So that shifts the nurse from being just a medication administrator to an active promoter of physical and psychological well-being.
Exactly.
Fluid and electrolyte balance is a minefield here due to fever, diarrhea, and the constant need for IV fluids for hydration and T-lysis prevention.
Accurate I&O and daily weights are foundational. We monitor potassium, magnesium, BUN, and creatinine meticulously. Many chemo agents, and often necessary antibiotics like amphotericin, cause electrolyte wasting, so aggressive replacement is often needed. We are constantly assessing for signs of dehydration versus the risk of fluid overload.
Turning to psychosocial support, we have to maintain dignity by encouraging self-care, even if we're assisting with hygiene. But the emotional toll of this diagnosis is just immense.
It truly is. The diagnosis is sudden, emergent, terrifying. The nurse has to be skilled in providing continuous emotional support, assessing the patient's desire for information frequently, and supporting them through the stages of grief. Grief for their health, but also for the loss of identity, roles, and normalcy.
And central to this is fostering realistic hope. Early on, the hope is for a cure. But as the disease becomes refractory, the nurse's role is supporting the patient as that hope transitions, maybe to hoping for symptom-free days or a quiet, dignified end of life.
Finally, transitional care can't be rushed. The patient leaves the hospital still deeply immunosuppressed. Self-care education must be crystal clear, teaching signs of infection and bleeding and meticulous training on their vascular access device care. They have to know the exact parameters. Call us immediately if your temperature is 100.4 Fahrenheit or higher.
Okay, we've put a bow on the acute leukemias. Now let's pivot to the family of clonal myeloid disorders that are not acute leukemia. We'll start with the dysfunctional disorders, the myelodysplastic syndromes, or MDSs.
MDSs are complex. They are clonal myeloid disorders that result in dysplasia, which is abnormal, ineffective development of blood cells. This leads to cytopenias.
But here's the key pathological insight. The bone marrow is usually hypercellular. It's overproducing cells, but those cells are faulty and die internally, leading to low counts in the circulation. It's ineffective hematopoiesis.
Precisely. So the cells that do make it into the bloodstream are often dysfunctional. Neutrophils can't phagocytize effectively, platelets are less sticky. The patient remains highly vulnerable to infection and bleeding.
MDS primarily affects older adults with a median age of 65 to 70. And while transformation to AML is a serious risk, the majority of patients actually succumb to complications from the disease itself, severe infections, bleeding, or other comorbidities, before that transformation ever happens.
Right. And diagnosis relies on sophisticated bone marrow analysis, and then a critical step, risk stratification, using tools like the IPSS score, which guides treatment.
And management is entirely risk-dependent. For low-risk patients, the focus is supportive. Transfusions and growth factors. Later stage or high-risk disease might use hypomethylating agents like azacitidine or decitabine.
And HSCT remains the only potential cure, but given the median age of the patient population, it's often not feasible. This is where we have to highlight a major unique challenge in MDS iron overload.
From all the transfusions.
Exactly. Since the anemia is chronic and the patient receives regular blood transfusions, sometimes hundreds over years, the body accumulates excess iron, which acts like a slow poison to the heart, liver, and endocrine glands.
So what's the nursing action here?
We meticulously monitor serum ferritin levels, aiming to keep them below 1,000. If overload is confirmed, we initiate iron chelation therapy using agents like deferocerox. Nursing education focuses on managing common side effects, diarrhea, cramping, and rigorous monitoring of renal function, as these drugs are nephrotoxic.
Okay, moving to the myeloproliferative neoplasms, or MPNs. Polycythemia vera is the most common of these, characterized by marrow hypercellularity but with a dominant explosion of erythrocytes. This causes the hematocrit to skyrocket, sometimes exceeding 60%.
And the clinical link is crucial. PV is highly associated with the JAK2 gene mutation, which keeps the hematopoietic system in overdrive, primarily producing red cells.
The symptoms are all rooted in increased blood viscosity. The blood is like sludge. We see neurologic symptoms like dizziness, headaches, TIAs. Abdominal complaints involve splenomegaly, leading to early satiety.
We also look for constitutional symptoms, fatigue and night sweats. But two unique dermatological symptoms are hallmarks: generalized pruritus, often triggered by water or temperature changes, and erythromelalgia, which is a painful, burning redness in the hands and feet.
And the primary risk and the leading cause of death is severe thrombosis strokes, MIs, DVTs, because the thickened blood just clots so easily.
The main treatment is strikingly simple: phlebotomy. We remove 500 milliliters of blood, often once or twice a week initially, to physically drop the hematocrit below 45%. This also strategically induces a mild iron deficiency, which helps limit further red blood cell production.
And low-dose aspirin is standard to minimize vascular risk. For high-risk patients, we add cytoreductive therapy like hydroxyurea or ruxolitinib, which is a JAK2 inhibitor.
Nursing management focuses heavily on symptom control. Managing that debilitating fatigue, Table 32 details multiple potential causes for it. For pruritus, teaching patients to use tepid baths and emollients is key, as antihistamines often fail.
And a major teaching point that needs emphasis. Patients must be strictly instructed to avoid all iron supplements, including those in multivitamins, as it counteracts the therapeutic effect of the phlebotomy.
Next is essential thrombocythemia, or ET. This is defined by an excessive proliferation of megakaryocytes, leading to a consistently high platelet count, often over 450,000, sometimes reaching into the millions.
While often asymptomatic, symptoms stem from vascular occlusion or thrombosis. Headaches and visual changes are common. But here is the major counterintuitive fact. Extremely high platelet counts, over 1.5 million, can paradoxically cause hemorrhage.
Let's walk through that mechanism again because it's a critical concept to grasp.
Please.
When platelet counts are astronomically high, the massive surface area of all those circulating platelets acts like a sponge, consuming and inactivating the circulating von Willebrand factor, or VWF, which is essential for normal clotting. Without functional VWF, the platelets can't adhere correctly, leading to a functional bleeding disorder despite the high counts.
Treatment depends on risk. Low-risk patients often only need low-dose aspirin. High-risk patients get cytoreductive therapy like hydroxyurea to keep the platelet count below 400,000.
Right, and nursing management here is vigilant monitoring for both bleeding and clotting signs, especially neurological symptoms. We stress cardiovascular risk factor modification and meticulous monitoring of CBCs.
Our final MPN is Primary Myelofibrosis, PMF. It's the rarest, defined by progressive scarring or fibrosis of the bone marrow. This forces blood cell production to move outside the marrow extramedullary hematopoiesis, primarily into the spleen and liver.
And the clinical picture is pretty grim. We see profound splenomegaly in 90% of patients, often extending to the pelvic brim. Patients suffer severe constitutional symptoms, debilitating fatigue, cachexia, and wasting, and often intense bone pain.
Since the marrow is essentially non-functional, treatment is primarily supportive and palliative.
Ruxolitinib is used extensively to manage the splenomegaly and constitutional symptoms, which significantly improves quality of life. However, HSCT remains the only treatment that can potentially reverse the marrow fibrosis, but it's limited to younger, healthier individuals.
Given that massive splenomegaly, what is the nurse's priority for comfort management? Analgesics often don't help with organ discomfort.
No, they don't. The massive spleen causes mechanical discomfort, leading to early satiety and poor nutritional intake. So nurses must focus on providing small, frequent, high-calorie, nutrient-dense meals. And crucially, due to the unrelenting fatigue, energy conservation strategies from Table 30-3 are taught and implemented to maximize their limited physical reserves.
We now move to the lymphoid malignancies, starting with the cancers of the lymph system itself.
Right.
First up, Hodgkin lymphoma, or HL. It's unique, relatively rare, often affecting younger adults, and highly curable, approaching 90% success in many stages. Pathologically, it starts unicentrically and spreads predictably along contiguous lymphatic chains.
And the absolute pathological hallmark, which you must know for any exam, is the presence of a gigantic, often multinucleated Reed-Sternberg cell.
The one that looks like an owl's eyes.
Exactly. Figure 30-7. That owl-like appearance is classic.
The clinical presentation usually begins with painless, firm lymphadenopathy, most commonly in the cervical region. A mediastinal mass may also cause signs like a persistent cough or dyspnea.
But again, the presence of B symptoms, that unexplained fever, drenching night sweats, and significant weight loss, indicates advanced disease, which directly impacts the Ann Arbor staging system.
Impaired cellular immunity is a huge consequence here, making patients highly susceptible to infections, notably herpes zoster. Treatment is aggressive combination chemo like ABVD, sometimes followed by radiation, because the goal is cure.
And since the goal is cure, the nursing student's focus has to shift to the long-term reality, late effects of treatment. This is a major area of required lifelong screening. Survivors need to be aggressively monitored for secondary malignancies, specifically lung and breast cancer, especially if they receive chest radiation.
And the cardiovascular risk is significant too, right?
Yes. Thoracic radiation increases the risk of premature coronary artery disease and valvular heart disease. Hypothyroidism is also extremely common, affecting up to 50% of survivors. So nurses have to be involved in educating patients on ACS recommendations and ensuring they adhere to lifelong specialty screenings.
Okay, what about non-Hodgkin lymphomas, or NHLs?
NHLs are a much more diverse and widespread group. They're heterogeneous, involve unpredictable spread, and frequently infiltrate extranodal sites like the GI tract, bone, or even skin.
And they're classified based on their speed and aggression. Indolent subtypes are slow-growing, sometimes managed with watchful waiting. Aggressive subtypes, like diffuse large B-cell lymphoma, are fast-growing and require immediate intensive combination chemo like CHOP.
Risk factors mirror many other lymphoid malignancies. Immune deficiencies like HIV, certain viral infections, and again, documented exposure to environmental toxins. Treatment involves chemo, often combined with a monoclonal antibody, usually rituximab, which targets the CD20 protein on B cells.
Let's detail the acute care complications for the aggressive NHLs. They carry a very high risk for tumor lysis syndrome post-chemo, similar to acute leukemias.
They do. And rituximab-containing regimens carry two other critical risks. One, They can trigger hepatitis B reactivation in previously exposed patients, requiring prophylactic antivirals. 2, in severely immunocompromised individuals, there is a risk with a fatal viral infection, progressive multifocal leukoencephalopathy, or PML.
Wow. Okay, so nursing management for both HL and NHL revolves around infection prevention and patient education on surveillance.
Absolutely. Meticulous hygiene and early identification of infection are non-negotiable.
Our final malignancy is multiple myeloma, a cancer of the mature plasma cell. These malignant cells reside primarily in the bone marrow and produce massive amounts of a non-functional antibody known as the M protein.
This condition often starts as a precursor state MGUS and progresses when the plasma cells begin secreting factors that activate osteoclasts, leading to widespread catastrophic bone destruction.
And this bone destruction defines the classic clinical manifestations, universally summarized by that critical acronym CRA. Every nursing student has to know this.
You do.
C, R, A, and B. Let's break down the clinical pathology of each letter.
C is for calcium, hypercalcemia caused by the continuous lysis and breakdown of bone matrix, releasing large amounts of calcium into the bloodstream. This causes confusion, fatigue, and can precipitate acute kidney injury.
R is for renal dysfunction, often called myeloma kidney. The kidneys are damaged by the hypercalcemia, but also by the deposition of the light chains of the M protein, the Bence-Jones proteins, in the renal tubules.
A is for anemia, caused by the massive crowding of the marrow by the malignant plasma cells, inhibiting normal hematopoiesis.
And B is for bone destruction, presenting as lytic lesions on X-ray, pathological fractures, severe worsening bone pain that's aggravated by movement, and the risk of spinal cord compression from vertebral collapse.
A quick diagnostic note. The peripheral smear may show rouleau formation, where red blood cells stack up like coins because of the high concentration of protein in the plasma.
There is still no cure, but treatment has shifted from palliative to dramatically prolonging survival. Therapy is guided by eligibility for an autologous stem cell transplant.
It is. For those eligible, the treatment strategy involves aggressive multi-drug regimens, often combining a proteasome inhibitor like bortezomib or an immunomodulatory drug like lenalidomide with high-dose steroids, followed by the collection and reinfusion of the patient's own stem cells.
And supportive care is non-negotiable.
Absolutely. Bisphosphonates, like pamidronate or zoledronic acid, are fundamental. They inhibit the destructive osteoclast activity, strengthening the bone, managing hypercalcemia, and significantly reducing skeletal events.
Nursing management starts with pain. Bone pain is often severe. We use opioids, but we have to use extreme caution with NSAIDs because of the existing risk of renal dysfunction.
Hypercalcemia management requires aggressive monitoring and intervention, copious hydration to flush the calcium, and ensuring patient mobility to minimize further calcium leaching from the bones.
And infection prophylaxis is vital, as patients have defective antibody production. Antivirals are standard when patients receive bortezomib to prevent herpes zoster, and antibiotics are often necessary when on heavy steroid regimens.
Finally, we must spend serious time on the major side effect of several primary agents. Peripheral neuropathy, or PN, which affects up to 75% of patients treated with thalidomide or bortezomib.
And this can be severely disabling. Since it's often a dose-limiting toxicity, prompt assessment is key to preventing permanent damage. We need to detail the comprehensive assessment required.
The source provides a vital assessment checklist, Table 30-6. Nurses have to assess for 3 categories of symptoms: sensory, numbness, tingling, burning pain;
Right.
motor, muscle cramps, loss of balance, gait disturbance, and foot drop; and autonomic symptoms like orthostatic hypotension.
The nursing implication is immediate. PN requires prompt reporting, rigorous home safety assessments for fall hazards, and often a mandatory reduction or cessation of the offending drug to prevent progression.
And one final risk, VTE. patients, especially those on immunomodulatory drugs combined with steroids, are hypercoagulable and need prophylactic anticoagulation and aggressive mobility promotion.
We have journeyed through an immense amount of material today, moving from the microscopic genetic errors that cause clonal stem cell disorders to the highly specialized, multi-phase treatments for these complex hematologic malignancies.
The real power of this deep dive, I think, lies in pattern recognition. For you as the nurse, it is about immediately identifying the clinical emergency, recognizing profound neutropenia, catching the subtle signs of tumor lysis syndrome, understanding the mechanical obstruction of leukostasis in CML, and assessing those deadly sera features in multiple myeloma.
And realizing that your role shifts dramatically, often mid-course, from acute toxicity management during induction to managing the long-term specific toxicities of oral targeted therapies like TKIs and immunomodulators, where patient education and adherence literally determine survival.
And if we circle back to the patient experience, the contrast between the high cure potential of Hodgkin lymphoma, which demands lifelong screening for late effects, versus the complexity of managing a chronic, ultimately terminal disease like multiple myeloma, it raises a profound ethical and emotional challenge.
The provocative thought we want to leave you with is this. When faced with the inevitable shift in goals, from cure to maximizing quality of life and dignity, how do you, as the nurse, maintain that essential element of compassionate, realistic hope? How do you pivot your emotional support and education to meet the patient exactly where they are in their disease trajectory?
Thank you for joining us for this intensive deep dive into the management of hematologic neoplasms. We hope this knowledge serves you well in your clinical practice.